they know that I don't like to stand in front of a camera. I will try to stay in place. I'm Chris Grimes. I'm one of the owners of Martin County Insurance there on the corner of McCaskey Road and Main Street in the little white brick building. Was a dry cleaners. Still have some of the pipes in the back of it. Been there forever, but been there. It's almost 20 years. 20 years that I've been one of the owners, or the owner. But I'm also a minister at Saints of Light Church of Christ in Roper. I am a descendant of Nathan Mayo and Thomas Grimes. I'm also one of the Keels. And I walked in today and was talking to Miss Betty, and she was we were talking. I said, I'm a Keel, and then I looked over and I saw everybody's cousin, Mike Taylor. And Mike, I'm just as bad as you are, because I'm going to find one way or the other, we're all kin. We're all kin. But it is my pleasure to be with you guys today. Back in 2009, I met a gentleman who lured me into the world of 18th century medicine. I lured him in the world of Civil War Navy, and I know all of y'all know about the CSS Albemarle, a ship that's near and dear to my heart. But we focus on 18th century medicine, and I actually am a reenactor that goes out, and I set up at living history events and battle reenactments and talk about the brutal craft of surgery and bleeding and purging when you're sick. And that's what we're going to be looking at today, the world of 18th century medicine. And let's see. Make sure we get the right one. There we go. So,
You're going forward.
no, I know. I wanted to get everybody on the screen.
Oh, okay.
So, when you think of Revolutionary War surgeons or physicians, and you think about the American side of things, today I want to be talking about American side. We won't get on the British side. I can come back and talk about that another time. But we look over here and we see the Honorable Dr. Benjamin Rush. We saw the Dr. John Morgan Jr. We see our very North Carolina's own Hugh Williamson. Dr. Joseph Warren. We just celebrated the Battle of Bunker Hill and the Battle of Lexington, Concord. All of that he was associated with. Another gentleman that a lot of you may not know, but he was instrumental dealing with smallpox and yellow fever with the troops up at Valley Forge, Dr. Bodo Otto. And then this gentleman here, who was the best friend of our first president, George Washington, and that's Dr. James Cramer. But all of these represent basically the creme de la creme of our medical practitioners. When you look at the United States as a whole, or the very beginning, you are seeing a very small percentage of our population would be medically trained. Now, the first person that you would have met as a doctor was who? And don't think physician, don't think surgeon, don't even think apothecary. It's Dr. Mom. That was the first person, the first doctor you ever met. And in fact, if you will go into the 18th century recipes books, or as they refer to them, the receipt books, there's always a chapter on medicine, basic treatments for ailments. Hit me. I'll let you do it.
No, it works that.
That's what I wanted to do.
No, it won't operate like that.
Oh, it don't operate the thing. Well,
Just operate that.
well, shoot. I thought you had a clicker. So, the first thing we will talk about, we talked about Dr. Mom a little bit, but when you talk about professional doctors, professional medical people, you're going to be looking at physicians, surgeons, and apothecaries. Now, here in the United States, it was a little different than it was in Europe. In Europe, these people literally stayed in their lane. Well, they were supposed to. In the United States, you saw these different medical professionals. They actually started practicing and crossing a lot of lines because our population is nowhere at the level that it is in Europe and Great Britain and Scotland and the like. Here, the doctor had to eat what he killed. So, that meant that he had to be an apothecary and a surgeon as well as a physician. Now, the true differences between these two kind of are fleshed out. Oh, I'll move back one. They had kind of their realm of specialty. And here is a picture of William Hogarth's Consultation of Physicians. And there they are in their wigs, and they're holding their canes up, because in the head of a physician's cane, typically, you're going to find a place where they would put a sponge soaked with vinegar, or they would have some kind of, I'll use the term potpourri, that was put in the head of the cane, thinking these scents would ward off any infection, so they wouldn't catch the illness, the disease. But here's an example, and literally what these guys did was they diagnosed. They literally did not touch the patient. One of our famous teachers, Dr. William Cullen out of Edinburgh, he literally would get letters from people who would describe their symptoms. He would write them back a prescription. And of course, they would send money with that first envelope, because otherwise he's not going to send them anything. But that's how we actually did some of our first telemedicine in the 18th century, and prior to that, really. But they did diagnosing only. Your next up would be your surgeons. Now, surgeons were apprentice trained. They were literally, they signed an agreement, a contract with a practicing surgeon, and they worked under that surgeon for 7 to 8 years. The only thing they were really supposed to do is cut. They were the actual, think of them as they were at times merged with the barbers, and it was called barber surgeons, and they'd cut your hair, bleed you, and yank a tooth, all in the same city. Talk about one-stop shop. But that the surgeons eventually split from the barbers and stayed on their own. And all they did was, they did bloodletting, and they did surgical operations, manual operations. And then you had your apothecaries. Now, this part of it is near and dear to my heart, because that's when I got into this, I started reading the different prescriptions and the different treatments for various diseases, and looking at what they were using as their treatments, because some of it was actually grown here. We could grow it. But as a professional apothecary or a professional physician, I would typically order all of my medicines through a distributor. But here's an example of them setting up in an apothecary shop. I would say the closest apothecary shop to Williamston would have been Edenton. I don't think we had one here. In fact, I know we did. What year was Williamston?
1774.
Okay, so it hadn't grown that much. Edenton would be the key part. Your next town would have been Tarboro, because it was quite the hustling, bustling town during the Revolution. So those would have been, and you would have had Halifax going north. So those would have been some of your key areas, key towns. But the apothecary shop, you would go in, you tell the apothecary your ailment, and he would prescribe something and usually go right to making it while you're there. He also did minor surgery. He was allowed to do that, which would involve bloodletting or teeth pulling, things of that nature. But for the most part, he was the maker. Think of a nurse practitioner rolled together with a pharmacist. That's essentially what he was. Okay, so that would be an example of. Actually, that's an example of an apothecary shop in the Netherlands. But English would have been the same. Now, so we talked about the practitioners. We talked about the idea that in America you had to do everything. And if you were a military doctor, if you were a military surgeon, you did everything. And a lot of your surgeons got their start as regimental surgeons, and they came fresh out of training at one of the bigger hospitals in England, or training with a surgeon here. They would have literally come out, and a lot come into practice. We'd also had a lot of young physicians that would have gone into the military, and they would have practiced medicine. But battlefield injuries we would have been seeing included gunshot wounds, bayonet wounds, and sword and saber wounds. The first treatment of those would have been amputations. While we knew anatomy pretty well, that was part of your training. You would go to anatomy classes at night, especially in the larger cities. You didn't see it here as much in America as you did in Europe and London. But you would have had anatomy classes, and you would have dissected human cadavers. Where do you think they got the cadavers from? Not necessarily. Here in America, not necessarily, because they did like to bury the dead and give them honorable burial. But if you were in the larger cities, they would go up to this dear lady and they would say, "Madam, your husband was a thief, and you're going to be left destitute. So we'll give you 5 shillings for his body." And of course, she's probably saying, "Well, yes. He's not worth anything to me now." So that would be that kind of exchange that would happen at the where they were hanging the thieves and the murderers and the like. You would also have grave robbers. They would literally, you put your order in with a grave robber, and he would deliver the package, if you will, at your back door in the middle of the night. But that's what they used typically to actually learn anatomy. So when it came to amputations, you were amputating arms and legs, fingers and toes, and if it penetrated the trunk of the body, most of the time that patient wasn't going to survive, because typically the bullet would actually strike an organ. And if it did, we couldn't repair that. Not that we didn't have the want to or the skill. It was the fact we couldn't transfuse blood effectively. And we had no concept of germ theory. Germ theory for us didn't occur really and truly until post-Civil War. Dr. Joseph Lister was actually doing his research. He's the father of antiseptic surgery, and he was doing his research and in Scotland during our Civil War. And in 1867, that's when he actually wrote his first paper on antiseptic surgery. But prior to that, no. We had no concept of washing the patient, sterilizing the instruments. We basically wanted to do the surgery as quick as possible. And that amputation, a good surgeon should be able to drop a limb within 2 to 3 minutes. And I would say at the most, you would see them, and I'm thinking from the very beginning all the way for him going into what we would call recovery today, would take up to maybe 10 minutes. Your next one your treatment would be extractions, and I got into that a little bit, but you would basically want to get the ball out, the musket ball that struck, or the piece of shrapnel, or if you're on board ship, you've got all those splinters that when a cannonball hits the side of the ship, that it would just shatter an individual, could shatter bones, depending on where it hit, could kill him dead. But extractions were one of your other deal, and we would literally go in. I have forceps that you would go in and you would extract the ball. One of the key things I'd also be looking for is what the ball drags in with it. Think about the clothing that I'm wearing today. Think about the layers. It would drag all that material into the bullet wound, and there's your source of infection. So you want to get that out. And we did have enough common sense to follow progression. If you left the cloth in, this is what's going to happen. If you get the cloth out, it's not going to happen. So you wouldn't have the infection. So that will be your next one. Another procedure is, let's see. Oh, I've got plenty of bald heads. I wish I'd brought my trephine today. Trephinations. Wayne would have been a perfect candidate. Perfect round. When you were when you are hit in the head and you start hemorrhaging, I've got to be, in other words, you're bleeding inside the skull. I've got to relieve that pressure. So how am I going to relieve it? I'm going to take a drill and I'm going to drill a piece of your skull out, and I'm going to let it come out. Here's the amazing thing. The bit that's on my 18th century, my reproduction 18th century trephine, and that's the instrument they refer to, is not much different than the one they use today, except today's has a cover over it that keeps it from going so deep. I jokingly told somebody, I said, yeah, the only difference is today we have Black & Decker drills that we attach our bit to. And the man I was talking to was a Black & Decker medical equipment salesperson. And he said, oh no, they use the ones out of Lowe's. I said, what? And he said, yeah, there was a hospital down in Texas, and they were their drill had gone on the fritz. He said, I gave them the model number to go to their local Lowe's and pick one up. And he said that's what they did. But trephinations are something, it was usually a roll of the dice on your survival. It was kind of a 50-50 chance of whether you would live or not. But you had to have it done or you knew you were going to die. Probably the biggest thing, the question mark that we don't have today, but they had in the 18th century, is in the 18th century, we didn't have MRI machines and we didn't have CAT scans. So we couldn't tell if there was any other damage. All we wanted to do is get the pressure down. And we did, and it worked. So trephinations is one of those other. And oh, by the way, amputations. What do you think my survival rate on an amputation would be? Now, fingers and toes, I can tell you that's probably that's well into the 90% range. And that's even in the 18th century. But what do you think somebody that shot below the upper arm or below the upper thigh, what do you think that survival rate would be?
25%.
Flip it.
52%?
Flip it. Meaning 75% on average, if I got to that patient, within the first 24 hours, and he didn't bleed out, so there's some caveats here, but if he didn't bleed out, it was on average 75% survival rate.
Even all the germs.
Even with all the germs, because we knew enough to clean the wounds. So one of the things I would do is, as I got a patient in, I would be using something like vinegar or turpentine to clean the wound. Notice I didn't say anything about sterilization. I didn't say anything. We didn't even get into that. I'm cleaning the wounds to remove debris and also to make sure that the smell of that wound doesn't drift into something I'll describe as rancid almonds. Once you ever smell gangrene, you'll never forget it.
Yep, that's true.
And so you would see, if we got a hold of most of our patients, we got their wounds cleaned, we got the amputation done, got their wounds cleaned, as long as we didn't see any complications, we would have a 75%, on average, 75% survival rate. And you saw that percentage carry through to the American Civil War. There was a dip in the early part of the war due to the fact that we had anesthesia in the 1860s, where we didn't have it in the 1770s, 1780s, and that surgeons were taking longer. But in the Revolutionary War, oh no, you got no anesthesia. You were biting on a stick, or you were biting on a piece of leather or a piece of rope, so you wouldn't break your teeth. And we would do it quickly. Hence why I said a good competent surgeon should be able to do it in 2 to 3 minutes. Now, let's go over. There are the instruments. That's actually an original set. I have a reproduction that's reasonably close to that. And I have an original saw, but doesn't have a blade. That's typically what you saw. There is an example. This is a Dutch painting of surgery being done in the aftermath of a battle. You see the curved knives, you see the straight saws. A couple of Hollywoodisms I want you to just block out of your mind, or do like I do when I see it on TV. I yell at the TV and go, no! You would look at the idea of introducing the saw as your very first surgical instrument on an amputation. That would be wrong. You would start with a curved knife that we saw in the previous picture that's extremely sharp, and I would make a circular cut all the way around the limb. Then, after making sure that there's nothing between me and that bone, then I would introduce the saw. So that's one of your Hollywoodisms. The other Hollywoodism, they talk about biting a bullet. Why am I going to give, I need those musket balls. So why am I going to give him something to chew on and to bite on? When I take that sharp knife and I start making that first cut, he's going to instantly go, ah! And where does that musket ball go? Yeah, and if we're lucky, it goes into his stomach. If we're not so lucky, it goes down his windpipe. I'm just going to literally look at my assistant and say, next. Because we're not operating in the cavity, the body itself, the cavity, the trunk. Because we know the more we get into that and the more infection you're going to have, the more blood loss you're going to have. And I don't have any way to stem the tide of the blood flow. Those are some of the things. Now, the third Hollywoodism. How many of y'all watched Marshall Dillon? We all watched Marshall Dillon. And what did old Doc do when he got ready to cut somebody's arm and leg off? He gave them he gave them a good drink of whiskey. Gotta get them drunk. Folks, as an 18th century practitioner, if you came to me drunk, I would send you away until you sobered up. Because we knew that if you had drank enough so that you didn't care that I was cutting your arm or leg off, that your blood was going to run much freer than a patient that was sober. Hence, when Mike Taylor's had a few glasses of wine and those eyes turn red, and those cheeks get red, it's where the alcohol has dilated your capillaries. And that's where you bleed like a sieve. It's terrible. So, those are 3 Hollywoodisms I will say don't believe. Okay.
Wouldn't they pass out when they did that first cut anyway?
Sometimes. They would pass out from shock. But there were many people during the 18th century, they knew it had to be done, and their mindset in regards to pain is totally different than ours. For me, for you, when I have a pain, I want a pill. Give me some aspirin. Give me Tylenol. Give me oxycodone if you've got some. In the 18th century, they knew pain was part of life and part of survival. So they would steel themselves. In fact, gentlemen, that's kind of how the gentlemen took it. They were gentlemen, and they could sustain themselves through this. All right, next up. And there's your trephination instruments. And there's me drilling into Wayne's head. Mm-hmm. Now, when you start to talk about diseases, and let me start off by saying with this, diseases were the major killer in any war, incident of war, any kind of police action up until the turn of the 20th century. It was a Russo-Japanese conflict right at the turn of the century that was actually where the numbers, the percentages switched, where battlefield injuries were they were the greater cause of death than it was actually disease. Think about soldiers through all the wars here in America. How many lives were lost to not battlefield injuries, but to disease? One of the world worst problems that we had was dealing with malaria, because everybody had malaria. We live in eastern North Carolina, for goodness sakes. We're near swamps, other bodies of water, and there are mosquitoes galore. Mosquitoes were carriers for malaria, so everybody had it. But we did have a treatment for it, and probably the most effective treatment that there is for malaria. I'm looking at my medical practitioner over here. You ever heard of something called the bark, or Sakona tree bark? Quinine. We had quinine. Had it for a couple of 100 years by the time of the Civil War. And it came out of Peru and that area of South America. And they really built an industry around the treatment for malaria. Now, we did not call it malaria. We called it an intermittent fever. It would come and go, and everything kind of came back, it would sap your strength. Malaria is a parasite, and the parasite will stay with you for your life. We had a gentleman down in Creswell. He was a retired minister. He went to the hospital. They couldn't figure out what was sapping his strength, causing him to get weaker and weaker. And one of the ER docs said, "Has he ever had malaria?" And the gentleman piped up. He said, "I contracted malaria as a missionary in my 20s. It was still there." They gave him quinine, and of course, all the symptoms went away. So malaria, we were in good shape there. But remember, if you ever come across it in your reading, it's also in the 18th century referred to as an intermittent fever. Next one was typhus. And there's a difference between typhus and typhoid fever. And typhus is where you're going to get into other parasites, other creepy crawlies that bite you, and that would kill. Then there's dysentery. There is pictures of apothecary chest. Now, as I had to prescribe other treatments, there are pictures of my glory, well, not mine, but one I'd like to have, clysters. Do you know what a clyster is? You ever heard of an enema syringe? We do a lot of that. And of course, bloodletting was involved. And there's your bloodletting instruments, your cupping glasses. And we talked about malaria. I kind of got ahead of myself. And we thought that all these diseases was the exhalations from the marshes or from the swamps, where the vegetable matter was decomposing. That's where we thought infection came from, not knowing the real cause of it. We were 100 years away from it. And the first case was, and I thought this was an interesting discovery, the first case of lasting malaria was in Jamestown. It wasn't here until we came. We brought malaria with us. And let's see, in case of time, I'm going to scoot through some of the exact symptoms, because otherwise we'll not have any time for change. There's quinine. There's typhus. There's the little critter. It's also called hospital fever and jail fever. And you know how it's transferred. It's typically by lice. And we would basically treat it with purgatives. And that's where your clysters came into play, and also things like mercury, tincture of rhubarb, and anybody ever heard of ipecac syrup? We would be using those to cleanse your digestive tract to make sure nothing's there that may be causing your symptoms. And that's where we get started. Then we get into probably one of the deadliest things that we ever experienced, which was dysentery. And this is actually a quote out of one of the medical texts. The dysentery may be occasioned by anything that obstructs the perspiration or renders the humors putrid. That's the 4 humors of the body. This is an early write-up. As damp beds, wet cloths, unwholesome diet, air, etc., but it is most frequently communicated by infection. And the infection they would refer to would be bad water and bad food. That's typically where dysentery diets start. The worst case of dysentery you would get, so you'd start out as diarrhea, you go to dysentery. Dysentery is where when you go to the bathroom, you would be expelling dried blood or already spent blood. When you got to this last place, it was known as the bloody flux. And what was happening was literally you were bleeding internally. You were hemorrhaging in your bowels, and it was fresh. You were hemorrhaging so quick it had no chance to dry up at all. And there is a 16th century drawing of the bloody flux. Now we have some death statistics I want to show you. I'm going to put them all up on the screen. Total battle casualties of the war, a little over 6,800 men. Total American deaths from disease, approximately 10,000. So look at your percentage difference. And then total British casualties, they didn't break theirs out, but there was around 24,000 total of the two. But with our American numbers, we can break it out and you can truly see the percentage from disease was higher than from battlefield injuries. Okay, so that you guys have some time to quiz me, because we're a little after 1 o'clock, I think. What time are we? How close?
It's 10 after 1.
Okay, usually I do this when I get freewheeling. It takes me about 45 minutes, so I've done okay this afternoon. Do you guys have any questions? And don't be shy. As I tell my church crowd, the only dumb question there is the one that's not asked. Ask anything. Now, I have given you handouts, one that I compiled on diseases, and another one my friend Mr. Williams compiled on surgery. Take those home. My contact information it's on the pamphlet. Actually, it should be on both of them. But feel free to reach out. I'm on the corner down here. Y'all hunt. We're home. Y'all can stop by anytime. I'll talk insurance. I'll talk medical stuff. You name it, we can talk about it. Wayne and I have. But I want to thank you for the privilege to be able to come before this August group. And if anytime you would need a fill-in or need me to come back, please feel free to call upon me. I've got some other presentations squirreled away that we can talk about. Well, thank you guys very much. For me, I can sit down at the dinner table and eat a good ribeye steak and talk about bleeding and purging and all that sort of stuff. Doesn't bother me. It doesn't faze me. But I sometimes wonder there are others that can't. So, but anyway, again, thank you for your attention and thank you for inviting me.
Thank you.